Okay, so thank you. Um, so in terms of the first discussion topic, there were numerous representations from different organisations, plus consumers as well, which was really nice to have a good discussion about that. I think overall we just noted that the process for discharge is very inconsistent, and that's across whatever organisation or service that people were coming from. So, for example, we were talking about private versus public. So obviously in the private section, it's determined by funding a lot of the time, whereas at Ovarian Cancer Australia, initially, if numbers are quite low, they have that they have the ability to see patients ongoing. However, as the numbers have now increased, it's really about discharging the low value, as we mentioned before, and that is really making sure that patients are okay with that. And so we sort of just talked about those sorts of things. In terms, are we going through all of the discussion points or just the first?
I reckon, no, do
all?
Yeah, because otherwise we won't be able to come back.
Yeah, that's what I'm thinking. So in terms of communicating discharge, so in terms, I'm just trying to get together my thoughts.
That's okay, you can just do a barrier.
Yeah, so maybe I'll do the barriers because we did talk a lot about that. So one of the big barriers for discharge was about the referrals management processes and the administration errors that can occur. Also, I guess when looking at the discharge guidelines, there's not much that sort of exists or people are sort of following. And again, it's all just inconsistent. And another big barrier was the GP relationship. So whether or not you had a really good relationship with your GP, whether your GP was wanting to take on that role, and some patients don't have GPs at all. Yeah.
Great, thank you. Fantastic. Thank you, Jodie and Table 1. Now Table 2, Nella, if you'll come up. And you can elaborate on 1, 2 and 3.
Thank you. Trying not to duplicate anything. For topic, for question 1 about the discharge processes, we had 2 really great examples of where there is a discharge criteria, and it is communicated. So one of them was for a community allied health, is that right? And so patients come into the service and goals are set, and when those goals are met, that is when the discharge occurs. And it's not super straightforward because everybody's different and has different goals, but it was nice that it was spoken about at the start, said at the start, and then continued to be followed up until discharge. And the GP and the communication was really important there as well. And then how lovely consumers shared their experience about how they were sort of the expectations at referral were communicated, and the follow-up plan and the discharge, and then really working closely with the GP in a shared care model for follow-up. And there was a rapid re-entry pathway which seemed to work quite smoothly when issues came up. So it was nice to hear some good things, but also echoed a lot of the things that you spoke about, Jodie. Then what was the next one? Communication. I think I've covered a bit of that. We talked a lot about the admin burden and how not having an electronic medical record makes things very difficult. And that was one of also the barriers, and that some of the, having that automated and electronic medical record can be really helpful, and the relationship with the GP.
Beautiful. Very good. Thank you. We've got 9 minutes left, so we've got 4 more tables. Thank you very much, Meg. If you feel free, it's one or two or two, but not three.
I'll be
So we actually, what was the first one? We didn't talk quite so much about how to determine whether a patient was ready for discharge, but we talked about what a good discharge looks like. And having just been discharged from the late effects clinic at Peter Mac, I know what it looks like, and I got a letter in the mail, and that's not a very good discharge, we didn't think. We thought that perhaps 1 or 2 visits beforehand, that should be communicated, it should be discussed, there should be a care plan, there should be communication with the GP, all of the things that you would hope that you would get as a patient. So that was a part of our discussion. And barriers, we talked very much about the difficulties of finding a GP, not knowing when you're discharged where you're going, who's going to be looking after you, about the costs, not just of GP visits, but of scans and tests and everything else that you're going to have, that all of a sudden the costs increase depending on how you're going, whether you're public, private, whether you can get yourself into a clinic. And a number of people talked about actually not having a regular GP. And so what do you do then? Where do you go? Who follows you up? So that was the thrust mostly of our discussion. Okay.
I'm going to go to table 4 and then to Helena, because I know that she's going to have to run back down again to be ready for the next bit. So Rebecca and then Helena.
So our table was mostly allied health and NGOs. So we had a bit of a different perspective, but very similar things coming out. We spoke a bit about the goal-directed care plan and how we obviously use that to guide the conversation with patients around checking in to see where they're at, to help them understand that goals are achieved from our perspective, but also using that to guide the next step to set up an action plan so that people are really clear about where to go to if this happens. We talked about the role of the GP and how that's important, that we do issue standard GP letters, but we're not issuing treatment summaries necessarily. There's a concern from a lot of consumers when we're talking with them about discharge to GP that the GP doesn't understand, and quite rightly so. The GP may not if they don't have a treatment summary and they're not fully abreast of what's happening. So we want to try and support that to happen more often so that GPs have that information and can better support the consumer. But we also know the issues out there in terms of access to appointments and what we can do to also ensure that there's responsibility assigned to different clinicians at key time points to also have that discussion, because we also think sometimes someone thinks someone else is doing it, or there's a lack of communication even just within the team around who's discussing it and when and those sorts of things.
Great. Thank you, Helena, and then we'll go to table 5 and 6.
Thank you, and thanks to everyone online. So I'm feeding back from our online group, and we still have over 50 people online. So thank you for staying and being so interactive. So for point number 1, most services that were in our group do not have clear discharge criteria. One service does provide a discharge summary of treatment received at a radiation therapy centre that goes back to the GP with radiation dose received, side effects and how to manage those, as well as a living well after cancer booklet. So that person got a big clap from our group. That's fantastic. We do have some survivorship clinics that provide a psychosocial assessment at the 12-month mark and feed those results back to the GP. We have another service that transitions people via the Wellness and Exercise program, which is co-run with Cancer Council Victoria, into a stepped program of cancer wellness. So that's another method. In terms of how these discharges are being communicated, we had survivorship care plans and a variety of whether they were in-house survivorship care plans or people using mycareplan.org.au. As well as some discharge summaries, and some people saying we provide a verbal update to the patient. We let them know you're being discharged from this service. There's nothing written, which they would like to improve, and they do let the patient know how they can re-access their service if need be, which is very reassuring to the patient. For topic 3, we had a number of the same points that have already been raised about GP access, cost, etc. So I won't touch on those again, but sometimes our own clinical practice determines how long people come to us for follow-up. We had an example from a CNC who said that they had a practice where people were keeping their ports in for chemotherapy for up to 10 years and needing to needing to come to the clinic every 6 to 8 weeks to make sure that their port remained safe. So those people were coming back to clinic every month and a half, 2 months, and they anecdotally had a higher chance of fear of cancer recurrence than the patients who now, more in line with their current clinical practice, are having their ports removed at the end of treatment. So thank you for sharing that example.
Great. Thank you very much, Helena, and thank you for all the people who have stuck around online. We'll let Helena walk leisurely pace to get down for the discussion for part 2. Table 5, and Karen, thank you.
Thank you. It's quite good coming a bit later than the rest because you've all said quite a lot of it. But just to confirm that there are some inconsistent processes for discharge. Generally, the individual clinicians on our table, and that covered allied health and nursing, and we have one researcher as well, generally they have it in their mind that they're doing it, that they should start at the beginning. But then the point was raised that when there are multiple clinicians involved for a patient, the coordination as to how that's happening within that team is not done so well and is lacking in terms of operationalising the discharge process. In terms of communication, a number of points have been made, but one that came out on our table was that it's really important to have regular communication points with the patient as part of not only the treatment, but as the discharge process and preparing them for it. And it was highlighted the importance of the administration people's roles that are in the health system as well, those professionals, in communicating and repeating messages. So sometimes patients may not hear it on one occasion, but if it's repeated by various people, including the admin, they might hear it. And so then they can do something with it and self-manage and feel better. And the final point was about barriers. The GP was mentioned a lot on our table, but a particular lens was that in more rural and remote areas, GP access is even worse. And so it becomes very, very, very challenging to refer back where that service is not there or it's inconsistent, so the relationship with the patient is weaker.
Right. Thank you. And finally, the table number 6. And I think we'll go in the opposite order next time, and so you'll be able to go easy. It's a team.
We figured holding the poster was too difficult. So yes, in terms of topic 1, we came from a varied background because a lot of our participants were not from patient-facing services. But we did talk about that we largely rely on, where it was applicable, we largely relied on traditional physician-based discharge plans. So it was more following the guidelines as opposed to being patient-centred. In topic 2, which is where I'm just going to peer over your head because I can't remember. How do we communicate discharge planning? Yeah, this was an interesting one that came up in our table because a lot of it centred around a lot of the terminology we use, and sometimes that terminology maybe doesn't resonate properly with the patient. So when we're talking about the terms admitted and discharged, that sometimes they don't mean that means you're being discharged for good and you're not actually getting seen. They just think it's from that particular inpatient stay or outpatient service itself. So finding other ways to really explain that in a meaningful way to the patients, and also recognising the needs of our culturally and linguistically diverse community, and making sure that our discharge plans are communicated in an appropriate way to them, both written and verbally with an interpreter. Point 3, we were talking about making what was the topic there? Sorry. Barriers. Yep, that's the one. My memory. We were talking about how making change, especially in public hospitals, can be quite difficult, and that we know best practice would be to be integrating things like survivorship care plans at the end of treatment, but to actually start doing that can often mean a lot of red tape and processes before you're able to start providing those to the patient, and different ways we can get over those barriers. And another one that came up, which hasn't been discussed previously, is actually the patient-clinician relationship and how that can often be a barrier to discharge. The patient's been with us for so long and seen quite regularly that they've developed a strong rapport, and there can be some hesitancy from the patient side to be discharged back to general care, and that can often be a tricky one to overcome.